important discussion on SGLT2 inhibitors. They have taken the field of diabetes treatment by storm, and all the speakers must have devoted their time sincerely. So it's our duty at least to give them a patient hearing and take home some important messages from this CME. Over to Dr. Bhawna Attri for her first presentation.
Good evening all. Thank you Sun Pharma and thank you a lovely audience who has taken out the time from their busy schedules. So taking the discussion further, I'll be talking about the combination fixed drug treatment with Dapagliflozin plus Sita, 2-Tango. The topic will be covered under the following headings, talking about the prevalence of diabetes, what are the unmet needs and the scope in the management. Specifically this combination, what is the evidence do we have regarding the efficacy, safety, cardiovascular, renal benefit? How this combination is going to be helpful, especially complementary mechanism of action, pharmacokinetics, efficacy, safety trials, and then the expert opinion, talking about the guidelines, and then concluding. So what does this 2-Tango means? Certain actions cannot be performed alone. Both the partners are responsible for the action. Basically, this fixed drug combination, Sita plus Dapa, together they are going to serve multiple purposes for the management of diabetes. In a way, they complete each other because some is performing some action, another is performing some action, and then we are going to have a double, quadruple benefit with the combination. So, prevalence of diabetes worldwide, we know that diabetes, India is now going to become the diabetes capital. And the problem with the Indians is not just the diabetes, such a huge burden of disease is undiagnosed. And in fact, huge of our diabetic population is poorly controlled. Many studies, many data has shown us from the North India, South India, that diabetes remains fairly uncontrolled in our country, and that has got many reasons, the poor education, the social, economic status, and a lot of things. So, prevalence of diabetes in India is really very bad. The prevalence is around was 7.1% in 2009, and now increased to 8.9 in 19, and expected to rise tremendously in the next coming years. Nearly 57% of adults with diabetes are undiagnosed in India, and the more figures with the impaired glucose tolerance, the population which we can target and then prevent the development of a full-blown diabetic disease. So why are Indians they are prone for diabetes? Because we have a certain phenotype, more of the visceral obesity, thin extremities. So that makes us more prone for the metabolic syndrome, for all the metabolic diseases per se, whether it is diabetes, hypertension, dyslipidemia, cardiovascular diseases, renal diseases. Plus urbanization is happening, people are going more prone for the sedentary lifestyle, and the eating habits have changed a lot. So everything is now culminating into the increased prevalence of poor disease. What are the unmet needs, especially for the Asian patients? One is, earlier we used to say that diabetes is only because of insulin deficiency, insulin resistance, but now we know the ominous uptake. Multiple pathophysiological pathways are working. So maybe we need combination treatment with different mechanism of action, working on those pathways and giving us the more benefit, more efficacy. Then not only the glycemic control, our approach is now not only the glucocentric approach, it is more of a complication-centric approach in the management of diabetes. So we need to have a look on the cardiovascular renal parameters. And then talking about the safety, we definitely want a drug which gives us the less chances of hypoglycemia and the less chances of weight gain. And again, if we have the combination treatment, the compliance will be very good, the pill burden will be less. So all these unmet needs can be fulfilled by the combination which I will be talking about. So Dapa and Sita, they have complementary mechanisms of action. Efficacy and safety is definitely better with the combination, and the pharmacokinetics of two drugs is almost similar. Talking about the complementary mechanism of action, we know that Dapagliflozin is an SGLT2 inhibitor. The mechanism of action is totally different from the DPP4 inhibitor. It's going to promote the glycosuria, and apart from that, it has got multiple pleiotropic benefits in terms of reduction in the weight, reduction in the blood pressure, reducing the intraglomerular pressure, reducing the ASCVD risk. Then DPP4 inhibitor is going to increase the levels of incretin in the body, GLP-1 and GIP-1. And along with that, it is going to basically increase the insulin secretion and decrease the glucagon production from the pancreas. So the mechanism of action of these two drugs are different. And as a result, with the DPP4, we'll have the efficacy in terms of glucose reduction. Along with that, the cardiovascular renal protection and weight reduction. With DPP4, it's basically the drug which most of us use so frequently because it is almost free of the side effects. Very well tolerated by a patient and the cost is not an issue. Efficacy is there, weight neutrality is there, and not of no major side effects. As I already said, the omnious off-state we talk about, the problem lies at the level of pancreas, alpha cells and beta cells. The problem lies at the level of brain, neurotransmission is affected, oxidative stress is there. The problem lies at the level of adipose tissue where inflammatory milieu is increasing in the diabetic patient. Then hepatic level, there is more and more production of glucose is happening, gluconeogenesis is increased, and at the level of muscles where the lipids are being broken down, fatty acid is released and glucose is not properly taken up by the muscles. So there are multiple reasons for the development of diabetes and its complication, not just insulin deficiency and insulin resistance. So talking second part, why we have come for these two drugs to form a combination. So for two molecules to combine together as a pill, there need to be certain properties that need to be matched with the pharmacokinetics. Of course, we need their half-life to be similar, we need their properties to be quite similar so as to get a stable interaction in the body, stable response in the body. So among the DPP4 inhibitor, we talked about the sitagliptin. The half-life is around 18 to 14 hours. Another gliptin with a larger half-life is the linagliptin. Vildagliptin is quite shorter. Talking about the renal excretion, the sitagliptin and the vildagliptin has got the renal excretion and the linagliptin has got the biliary excretion, and that is why lina is being preferred in the patient with the end-stage renal disease as well. Similarly, the dapagliflozin, the half-life is almost 13 hours and the excretion is through the renal route. And with both the sitagliptin and the dapagliflozin, there are not much drug-drug interaction. So that makes them a good molecule to be combined with a similar half-life requiring once a day dosing. Talking about the efficacy and the safety, both of these molecules complement each other. So we know that diabetes, as I said, just not the glucose-centric approach. We need to have a cardiovascular renal approach for our patients. Almost, I think 10 to 40, maybe 20 to 40 patients of diabetes have got heart failure, they have ASCVD, they have renal disease. And the people with renal disease are very prone for heart failure, again CVD, and at very high risk of mortality. So that is why this is very important for us to, whenever a patient comes to our clinic, to screen for all these complications by history, examination and some basic simple tests so as to intervene early and to do primary or the secondary prevention of these complications. Talking about the evidence, we have got major landmark trials for the dapagliflozin, be it DECLARE-TB, be it Dapa heart failure, Dapa CKD and DELEVER. DECLARE-TB was planned for diabetic patient to prove the safety. The primary outcome was to have the 3-point MACE. It should be non-inferior, there should not be any cardiovascular risk. But when this trial was conducted, along the side dapagliflozin showing the benefit, so secondary outcomes were added in the trial to see the cardiovascular death or the heart failure hospitalization. And when the results were out, we found out that there was reduction in the cardiovascular death and the heart failure hospitalization, although not significant reduction in the MACE. it was non-inferior. But when we cannot compare this molecule with the empagliflozin, because in the EMPA-RED trial, the predominantly 99% of population was having established CVD, whereas in the declared TME, we had majority of patients with multiple risk factor and without CVD. So the baseline character should always be looked upon by comparing the two molecules in the trial. And similarly, in the declared TME, many patients, all the patients had eGFR of more than 60, whereas in EMPA-RED trial, the inclusion criteria included the eGFR of more than 30. So the results of declared TME can be applied over the more generalized population of diabetes. We are having more idea about the primary prevention. Talking about the Dapa heart failure and Dapa CKD, these are the trials which are conducted on the people who are non-diabetic as well. There are almost 40 to 60% of patients who are non-diabetic in these trials. So dapagliflozin had shown its benefit in the non-diabetic patient also in terms of reduction in the renal event as well as in terms of reduction in the cardiovascular death or the heart failure hospitalization. And then the latest delivered trial published in NEGM, it has shown that not only the patient with ejection fraction 40, but also the patient who had ejection fraction of more than 40, in fact the normal ejection fraction with the heart failure, they are also benefited in terms of the cardiovascular death or heart failure hospitalization. The DELIVER study is the most recent landmark trial of dapagliflozin conducted in the patients who had mildly reduced or preserved ejection fraction. So the patient of chronic heart failure with ejection fraction of more than 40. It was a randomized double-blind placebo-controlled trial, and the primary outcome was either the cardiovascular death or worsening heart failure in patients with heart failure in mildly reduced or preserved ejection fraction. Eligibility criteria was more than 40 years of age, NYHA class 2 to 4, ejection fraction should be more than 40% at the time of inclusion, some structural heart disease should be there, elevated natriuretic peptide, and patient is having heart failure. So dapagliflozin 10 was added in the along with the placebo. So we can see from the results that the primary endpoint overall in the full population, also in the population with less than 60% ejection fraction, there was the reduction in the event in the dapagliflozin group versus the placebo, and the p-value was so low that it was statistically significant. So dapagliflozin has shown improvement, the reduction in the cardiovascular death or heart failure hospitalization in people with preserved or mildly reduced ejection fraction. Total heart failure event, like throughout the study group, how many heart failure event happened in the patient and cardiovascular death, this secondary outcome was also better with dapagliflozin versus placebo. So the conclusion was that DELIVER study is the largest and the most inclusive trial of patients with heart failure and mildly reduced or preserved ejection fraction treatment with dapagliflozin, and it reduces the risk of primary composite outcome of CV death or worsening heart failure. It reduces all the components of composite total heart failure event and cardiovascular death. And the results, as I said, are consistent over all the ranges of ejection fraction. Coming up with the pooled meta-analysis, so they conducted the meta-analysis so as to take the patients with all ranges of ejection fraction. Dapa heart failure had all the patients with ejection fraction less than 40, and DELIVER had all the patients with ejection fraction more than 40. So did the meta-analysis to see how the results were variable among these subgroups. So what they found out that whether it is a cardiovascular death or it is the total heart failure hospitalization, it was definitely reduced with dapagliflozin irrespective of ejection fraction, although there was not much significant difference in the MACE in both the trials. So we can see the consistency of benefit across the range of ejection fraction in both these trials for almost all the outcomes, whether it is cardiovascular death, all-cause mortality, heart failure hospitalization, 3-point MACE, which include CVD death, non-fatal MI or the non-fatal stroke. So again the same slide. The dapagliflozin reduces the mortality from heart failure, cardiovascular death, irrespective of ejection fraction in patients with heart failure. So DECLARE TB was the first trial, and the primary endpoint of this trial was the MACE, 3-point MACE. Along with that, they also seen the cardiovascular death, hospitalization for heart failure, renal composite outcome, whether there was decrease in the eGFR by more than 40% or end-stage renal disease or requirement of dialysis or death, and all-cause mortality. So we can see from that in terms of the cardiovascular death and the heart failure hospitalization and the renal composite outcome, definitely the dapagliflozin benefited with a significant p-value. MACE, and from the point of MACE endpoint, there was the non-inferiority in the DECLARE TB trial. And as I said, because the population that we included was more generalized, they had multiple ASCVD risks, not like all had the cardiovascular diseases. So probably that may be the reason that it not showed those wonderful results which were shown with the dapagliflozin. Talking about the Dapa CKD, primary and secondary outcomes. Primary outcome was decline in eGFR by more than 50%, development of end-stage renal disease or death due to renal or cardiovascular death. So versus the placebo, the number of events in dapagliflozin group was significantly lower, and almost all the secondary outcome like cardiovascular death or heart failure hospitalization was also significantly lower in this group. We know that the CKD patient, the main reason for mortality turns out to be cardiovascular death or the heart failure. So these parameters were very well taken care by dapagliflozin in the trial group. So the key points that we got from these trials of the dapagliflozin, the landmark trials, the dapagliflozin in heart failure is effective even in the patient who had mildly reduced or preserved ejection fraction, and consistency of effect can be seen across all the ranges of ejection fraction. Cardioprotective and renal benefit of dapagliflozin, they are extended beyond people with diabetes, because as we have seen that in Dapa heart failure and the Dapa CKD trial, many of the patients were non-diabetic. These trials will be discussed in details in further session. So there was a just quick review of the results. Coming on to the second molecule, what is the sitagliptin, what evidence do we have for this? TIGOS trial was conducted to evaluate the cardiovascular outcomes with the sitagliptin. There was the concern of heart failure with sitagliptin, which was there in the trials. So in this trial specifically, these outcomes were studied. So the inclusion criteria was age more than 50 with type 2 diabetes, A1C of 6.5 to 8, was receiving stable dose of OADs or non-insulin. Sitagliptin versus placebo, there was a median follow-up of 3 years, and the primary endpoints was the cardiovascular death, non-fatal stroke, non-fatal MI, and unstable angina, basically 4-point MACE. Baseline characters of both the groups were almost similar, no confounding factor. So the sitagliptin has shown non-inferiority to placebo in the primary 4-point MACE outcomes. So there was no concern of heart failure with sitagliptin, as we can see from the TIGOS trial. So the hospitalization for heart failure or cardiovascular death plus hospitalization for heart failure, we can see that there was no difference between the placebo and the sitagliptin. So conclusion, sitagliptin was non-inferior to placebo on primary 4-point MACE endpoint. Again, no difference in the rate of hospitalization and CV risk. They did the subgroup analysis also, like people who had cardiovascular diseases or multiple risk factors for those. In them also there was non-inferior results. So that definitely proved the safety of this molecule in terms of heart failure. Talking about the side effects of this molecule, as an overall we know that gliptin does not pose much challenges, they are better tolerable. There are few concerns should not be given to the patient with pancreatitis. or pancreatic malignancy, both DPP4 and GLP1 incretin should not be given. Apart from that, there are not much concern, but definitely in the patients with renal problem, they need dose modification. Less than 45 eGFR, the dose of Sita and Yadav need to be reduced to half, and Lina can be given to any stage. In the hepatic failure, mild to moderate, we can give because we have data for the safety, but in the severe hepatic failure, we don't have a data, so we should not use them. Talking about the expert opinion for the fixed dose combination of these two molecules. So this is a study from India, from Dr. V. Mohan, that optimal clinical approach to combination.
Dr. Bhawna, you have exactly 3 minutes now to wind it up. 3 minutes.
Okay. Optimal clinical approach to combination use of SGLT2i. So combination is good in terms of glycemic factor, combination is good based on the cardiovascular risk, based on the CKD risk. It promote the weight loss and prevent hypoglycemia because of course it has got SGLT2 inhibitor. So I think the unmet needs we talked about in the first slide, they are all, most of them are being managed by this fixed dose combination. So where practically it can be given, in diabetes management, there are few things like metabolic memory, we talked about legacy effect. So whenever patient come to us at diagnosis, it is very important to have an early and good control. So that control now requires combination treatment. So we should not stop ourselves for just like metformin lifestyle modification because patient who has come with an A1C of more than 8%. So it's always better to add a combination. So this combination can be given at diagnosis to people who are intolerant to metformin, otherwise would be given metformin plus gliptin. Secondly, people with on metformin who are not controlled, still having A1C of more than 8%. And of course, all the patient who has got ASCVD, renal issues, heart failure issues, SGLT2 inhibitor is the drug of choice or along with the GLP1 receptor analogs. So as I said, cardiovascular renal benefit, this is an effective drug and there are no chances of weight gain and minimal chances of hypoglycemia. So Indian patient, it is good in terms of efficacy, safety, promoting the beta cell function because DPP4 is there, SGLT2 inhibitor are there. Extra glycemic benefit, cardiovascular, renal, and of course the pill burden will reduce, the compliance will improve. That's all.
Will you stay for the question answer or we'll have the question answer session now?
I'm okay with it.
Staying? Will you stay? If you stay, it will be wonderful because then we will have a wonderful session with all the 3 great speakers today. Thank you so much. Now it's my duty to invite my close friend Dr. Mitendra Singh Yadav to speak on the heart failure aspect of SGLT2 inhibitors. Just a small prelude to his talk. This is the only parameter on which all the SGLT2 inhibitors have 10 on 10. Whether it is EMPA, whether it is CANA, whether it is Dapa, whether it is R2 or any other SGLT2 inhibitor, they have scored very well on heart failure front. And Dr. Bhawna showed some trial data on PCOS. You would remember the famous or infamous trial data of Savotimi with saxagliptin, which actually spelled doom for saxagliptin because there was increased hospitalization because of heart failure. So you have to choose molecules which are not only safe, but if they can provide cardiovascular benefits, that would add diamonds to their value. Over to Dr. Mitendra Singh Yadav to speak on the heart failure aspect of SGLT2 inhibitors. Over to you, sir.
Good evening, everybody. First of all, I would like to thank Physician Forum of India. And I have been a frequent visitor. When I was junior consultant, I was a consultant, I was a senior consultant. Now I am, with all good blessings of Chauhan, I am a principal consultant now. And I wish to continue that. So, then I would like to thank the Sun Pharma for organizing such wonderful CME, where you have one endocrinologist, eminent endocrinologist, you have a nephrologist, and of course you have a cardiologist also. I would not like to go into the statistics because for us we understand there is a p-value, there is a relative risk reduction. there is an NNT or number needed to treat. And there is another thing, there is a comparative diagram. If something falls on the left side, one thing is better. Something falls on the right side, the one thing, other thing is better. So I won't dissect the statistics, but we will go into the gist and we will go into the crux of the things. So to brief the things as Dr. Chauhan has told, most of the people have been, they are much more senior to me. But in my UG days in 1998, when we used to read pharmacology, then there was a molecule called beta blocker. So the contraindications of beta blocker used to be diabetes mellitus, peripheral artery disease, and heart failure. There was a time. Then the treatment for heart failure used to be eye-sealing diuretics, and then later on maybe MRI. This all came very late. And then you had revascularization if you could do, or peripheral structural heart disease by surgery or by intervention. Obviously it was surgery. Then over a period of time, AC inhibitor came when the HOPE trial came. And then those who could not tolerate, then the ARBs came in the picture. So, and then for a very long period there was a pause. Then some data came, then now beta blockers are the number one drugs. The one which was the contraindicated, we get the class 1 indication, then you have 3 molecules, carvedilol and bisoprolol and metoprolol succeeded. Then for a long time we had no molecule. We were left with, putting the ICDs, CRTDs, people tried to do LV reductions and so many fancy things. Then TAS, myocardial, lasers, TMR and those all things. Then we were lucky to witness an era when we had at least 3 wonderful molecules. The one came RD, we know now that after paradigm, actually it was a paradigm shift. So you had an RD and then we had this molecule which is a picture which we will go and discuss in detail. And then now we have another molecule. I'll just say one line for that. That is the working heart failure. So witness 3 wonderful molecules. So on top of revascularization and correction of the structural heart disease, we have almost 7 molecules now. So I'll talk about the SGLT2 inhibitors. Dr. Chauhan has in the beginning given a very crisp summary of the molecule itself, and Dr. Bhawna has elaborated about the uses in diabetes mellitus, so I won't go into this all. Roughly there is almost 1% population, like we are 1.4 billion. So you can assume that around 14 lakh people in India are having a heart failure, maybe symptomatic, asymptomatic. And out of them almost 1% are having a risk of dying every year. So that is the total summary you could see. The estimated prevalence of heart failure data from India if you could see. And then we have an estimated mortality of heart failure around 0.1 to 1.16. Almost 1 lakh to 1.56 lakh people, 1.6 lakh people are dying because of heart failure because of this. And then you have the study design, and then there is a comorbidities along with that. So now there was a Mitendra heart study. So if you see that the class 3 NYHA, the last 3 are NYHA class 2, 3 and 4 the prevalence. So class 3 NYHA, if you see, there are the maximum numbers. So total out of 895, 646 patients are in there. And those who have comorbidities around hypertension and diabetes is the maximum number. So this is so far the prevalence. Now prevalence of unknown HFpEF and HFrEF in diabetes mellitus. Unknown means they have underlying milieu for heart failure. Clinically they do not have. So what we call class 2, class 3. So if we go into the A, B, C, D classification of the heart failure, there was a time that we used to define heart failure in NYHA class 1, class 2, class 3, class 4, and we defined that the symptoms of the heart failure are on more than ordinary physical activity, at ordinary physical activity, more than ordinary physical activity, and the class 4 is that symptoms are at rest or no physical activity can be carried out without the symptoms. Now then we realized and we understood that not just symptoms, even before that. So what we call pre-heart failure. You have risk factors to develop heart failure. So there is one A, there are risk factors to develop heart failure, but there is no structural heart disease. Then there is a structural heart disease, stage B, but still the symptoms are not there. And there is a stage C, like your hypertension, no heart failure. Stage B will be the hypertensive guide and either mitral regurgitation or LA dilatation or blood pressure hypertrophy. Then subsequently you might be leading to LV dysfunction, systolic or diastolic, and then heart failure. So this is ABCD. Whole idea is to pick up the heart failure much before it happens. Then if you talk of the therapies of the heart failure to survival, before this molecule, if you see, it's a very poor. Their heart failure is considered worse than any malignant disease. It is the cause of the most important and largest cause of hospitalization and re-hospitalization worldwide, if you see. So if you see, the 1 year survival is somewhere less than 80%. The 5 year survival is below 50%, and then 10 year survival is less than 20% before the therapies came into the picture. Now, hyperglycemic therapy with diabetes mellitus. So as Dr. Bhawna elaborated, the molecule came in treatment for diabetes. But then people did the subgroup analysis and they realized that in diabetes also those did not have any apparent heart failure or those who have heart failure. This therapy were useful. So the trial she has quoted, so that it started like treating the patients with diabetes, and then we found to have effect on heart failure. Then people hypothesized that should we treat this, this molecule should be used in the people who do not have diabetes. Then surprisingly the trial showed that people who do not have even diabetes, they are also reduced the heart failure. Then whether with heart failure with reduced ejection fraction, mildly reduced ejection fraction or preserved ejection fraction. And then to your surprise, this is the only molecule in the spectrum of heart failure therapy. It is used in all three classifications, I say. One, the NYHA classes. So class 4 obviously you stabilize when the dose of diuretic and dobutamine or inotrope is stabilized. You start. Class 2, obviously class 3 and class 1. Then LV ejection fraction decrease less than 35 to 45, which is moderately reduced, more than 45, which is preserved ejection fraction. And then those who do not have symptoms of heart failure, those who have just they are little, they have substrate or we do for hypertension. So this Yadav is already covered. So if you think you have to start, if you think there is a underlying cardiovascular risk factor along with the diabetes mellitus, this is the first molecule of choice. SGLT2 inhibitor or the other one you can have is GLP-1 analog on top of metformin if somebody is taking the metformin. So if we talk about, this has been covered, so declared trial has been covered and we are going to the gist of that. So if you see heart failure with reduced ejection fraction versus preserved ejection fraction. The upper one will show you that there is a significant, the blue line is with Dapagliflozin and heart failure. The red line on top is Dapagliflozin with reduced ejection fraction and heart failure. There is a clear-cut difference and p-value is 0.04, quite significant. So this is cardiovascular death, hospitalization for heart failure, and in both HFrEF versus HFMRF or moderately reduced subgroup. Same is with the hospitalization for heart failure and CV death. If we dissect further, definitely Dapagliflozin was much better. All-cause mortality, which is one of the most strong primary endpoints. So if you see the HFrEF versus not HFrEF subgroup, and then you see there is in the HFrEF subgroup, you see significant reduction in the mortality, all-cause mortality. So now reduction in hospitalization for heart failure was observed across the SGLT2 inhibitor in cardiovascular outcome trials. So if you see the AMPA, REC trial, Canvas trial, and then declared trial. So if you see relative risk reduction, if you see with this molecule, and then in these all molecule trials, it was a tune of 30 to 35% reduction in hospitalization for heart failure with SGLT2 inhibitors. And there was a significant risk reduction in cardiovascular mortality. So as I told you, if you look at this line, the central line, I will show you. So this is the hazard ratio. So if you see the bottom vector, this favors the treatment, this favors the placebo. So in all other trials and meta-analysis, we see the cardiovascular outcome trials, the hospitalization for heart failure or CV death by presence of heart failure. So if you see all subgroups, it favors treatment. If you see that most of the dots are falling on the left side. So obviously most of the parameters are in favor of this molecule as compared to the placebo. Now if we compare the side effects, so obviously this molecule has certain things like it causes glycosuria, as Chauhan has told. So genitourinary tract infection is one of the concerns, but yes, with a proper teaching to the patients about the hygiene of the genitourinary tract, you can reduce it significantly. And risk versus benefit is quite high. Then there may be a risk of diuresis, dehydration, so you have to be very cautious when you're using the other diuretics with this molecule. And then obviously interaction with the other hypoglycemic agents. So you have to choose the other agents. Otherwise it is relatively much safer drug. So on top of the conventional therapy, it has got the additional years of survival. If you see in the both curves, the lower curve shows the on top of the conventional therapy, it gives you the additional survival of around 6 to 8 years on top of the conventional therapy. And then trials with diabetes mellitus and trials without diabetes mellitus. These are trials with diabetes mellitus, as I told you. So it has been shown to be effective in patients with diabetes as well as without diabetes. Now if we talk of the heart failure with preserved ejection fraction and Dapagliflozin. So this is a trial delivered. So the whole idea was to see, as it has been discussed, if EF is more than 40%, whether this molecule is effective or not. Again, so if you see the primary end was CV, death, worsening heart failure, so obviously they favor the Dapagliflozin treatment. Secondary outcomes, obviously they were in the favor of Dapagliflozin. So I would like to go, now we know that in all trials it has been shown in all subgroups. And then pre-heart failure, in heart failure, with all spectrums of ejection fraction and NYC class. So if we see the pooled analysis, large population with heart failure, Dapagliflozin reduce the risk of CV deaths and all-cause mortality, heart failure, hospitalization, death, and stroke. Benefit of Dapagliflozin were observed in all patients regardless EF. They were seen in regardless EF are likely to benefit by treatment with this molecule. And this should be initiated in the patient with a clinical diagnosis of heart failure and no contraindication while awaiting for measurement. So if you see there is a heart failure, you don't need to wait for the echo. You can upfront start and then you can get the echocardiography done. So now what is so specific? One thing just says that it is just giving some glycosuria and diuretic. So how is it going to affect? But it is something beyond that. Like we talk about statins, there are a lot of pleiotropic effects and on top of reducing PNK. Same with the molecules, the hypothesis, and it has been proven in many trials also. So what it does? Net uresis, obviously reducing the volume overload and then stretching away from the atria and ventricle and reducing the level of BNPs and ENTs. Then improving the cardiac biogenesis, the metabolism towards the favorable one rather than the negative remodeling. Inhibition of the cardiac sodium hydrogen exchange, again a favorable metabolic event. Then you have reduction in the intestinal edema. So any diabetic will work on that, and if you see that the initial heart failure patients are highly congested, oral therapy doesn't work because of gut edema. So then we use IV diuretic. One of the purpose is that they say edematous gut takes one paper. So same this molecule reduces the intestinal edema. Will make your other molecules very effective after the gut edema is gone. Then reduction in the preload. Obviously it is causing antiuresis, diuresis, then the preload of the heart is reduced. And then wall stress is reduced, so ultimately it's a favorable remodeling. The failing ejection fraction of the heart or failing LV will be going towards the improvement. And then improved kidney function and cardiorenal physiology, which Dr. Sahil will be further, that's it in this aspect. So if we see there are trials in therapies in HFpEF. So we'll go into that. This is a little crowded slide. So last slide, I'll just improve that. If we talk about the spectrum of heart failure throughout the ejection fraction, which are the molecules and where at what ejection fraction they are actually effective. So the timeline of SGLT2 trials, if you see, started with, this is the duration, if you see. So it started with a few months. It was started after 24 to 48 hours of the hospitalization heart failure control. And then in this trial, it was almost 37 months. So right from few weeks to 37 months, and then the overall outcome was in favor of this molecule in heart failure. So here I would like to correct this Arni. Right now there is no indication of Arni preserved ejection fraction. So I put Arni somewhere here, below 45. But if you see ejection fraction right from 0 can't be there. So anywhere 15, 20, whatever it is. And then 60 is the normal ones. Above 60 is in certain pathological conditions like hypertrophic cardiomyopathy or severe AR with preserved LV, where we say it is more than 60. But then in that also, so all spectrums of ejection fraction. Evaporating is having a selective role on top of beta blocker or those who cannot tolerate the beta blocker. So it's not a replacement of beta blocker. Then beta blockers, obviously, as I discussed. The three beta blockers, not everyone. Metoprolol, not targeted, but sustained extended release. Bisoprolol and targeted. Then AC inhibitor, not tolerated, then ARVs. And then MRAs came in the picture. And then another thing with this molecule is that the MRAs cause hyperkalemia along with anything, AC, ARV or ARNI. And that gliflozins have a very fantastic property that they increase the tolerance. By their diuretic effect, they increase the tolerance for eplerenone or aldosterone antagonist. And that is something which is an additional benefit. So MRA again in the EF up to 40%. Then we have ARNI as I have discussed. And then on top of ARNI, you have the SGLT2 inhibitor. And this is the only molecule which is used in all spectrums of ejection fraction. This is the wonder of this drug. So you have to start that. And then what guidelines say that you have the stages I have discussed. I am not going to do. So stage A, there are risk factors, no heart failure. B, pre-heart failure. C, structural heart disease like LA dilatation or LVH. And then you have mild heart failure symptoms. And then, so this is the trajectory of heart failure. So the guidelines say that primary prevention is important. Like if you have heart failure, you treat it so that the patient does not develop LA dilatation or left ventricular hypertrophy. So whatever risk factor is there, you have to control it so it doesn't affect the heart structurally. That is the best thing you can do. When the symptoms are setting in, then you have to treat them symptomatically as well as the therapy, which is helpful in symptomatic as well as survival benefit. So the primary prevention and preventing the syndrome, these are the stage A and stage B of heart failure. So guideline directed medical therapy, if you talk on top of that, patient with HAP should be given RD, class 1 indication. Level of evidence A. And then AC inhibitor should be used in the patients, where RD cannot be used or not feasible because RDs can cause a very significant hypotension. So you can start with the AC. And then one thing is very important that many people have seen using AC as well as RD. It should not be done. If you're using any AC inhibitor, you stop it for 48 hours, then you start RD. And then ARV, yes, you can switch very next day. Patients with chronic symptoms of heart failure, class 2 to 3, who are tolerant to AC or ARV, replacement with RV should be done. Like initially BP was 100, you were skeptical about RV. You started AC inhibitor arbitrarily. The BP went to 110, you start with a half dose of therapeutic and then gradually you build it. So whenever you feel that a patient is suitable, you start it. Then beta blockers, obviously class 1 indication level of evidence A. Then MRAs obviously, but the cutoff is that J1 should be more than 30 ml per minute per meter square. And then in patients with symptomatic chronic HAP-RAP, SGLT2 are recommended to reduce hospitalization for heart failure and CV mortality irrespective of presence of diabetes. Again, class 1 indication and level of evidence A. Strong recommendation. So this we have gone through. Now I will just go to something very important, the rapid sequencing. So rapid sequencing is, rather than going to these all things, we will go in this. So, big question comes that a patient came with a heart failure, how to use these all different molecules. We used to call 4 pillars, now we have 5 pillars to heart failure. So first of all, recognize whether this is, so even before ejection fraction, you can start the one thing, this is SGLT2 inhibitors. You diagnose the patient with risk factors and ejection fraction and functional class. If a patient qualifies for a BP which is suitable for RD, you start with RD. You address the RAS system. There are certain patients who are not having the blood pressure in your favor, then you start them with MRAs and then you start them with the SGLT2. And then if they are worsening, you can use Bagai. The moment you feel that they are coming in a zone where you can start them with any AC, ARV or RV, then you start them. So this can be the first thing to start with. And then they say within a period of 2 to 3 weeks or 4 weeks, you should be able to start at least 3 to 4 molecules. So we call that rapid sequencing. Systolic BP more than 100, as I told you, you start with early and then MRI. If your systolic BP is less than 100, you go with SGLT2. In both cases, with the first molecule. Then you go with MRI, once the BP alone, then you go with early. So, evidence supporting the increased filtration importance diagnosis of heart failure, like BNP levels, you should know. BNP level diastolic function on your echo simply doing the diastolic imaging and then tissue Doppler at the mitral valve. And this is a stepwise approach in patients with shortness of breath. So you examine if there is any other system involved, liver, kidney or something else. If not, then you should see whether there is a systolic or diastolic heart failure. Then you see the levels of ASTs and BSPs, and then you treat accordingly, whether it's FPAP, FMRF, or FRF, or reduced ejection fraction. So SGLT2 inhibitors have a strong recommendation, and then you have to titrate. Then you add Dapa diuretics, MRS. And ARV depending on that. So in patients with a heart failure, SGLT2 leads to significant reduction in the risk of all major events. And irrespective of PF, there was a large reduction in total hospitalization because of heart failure in there. Most patients with heart failure regardless EF are likely to be benefited with this molecule. And these can be initiated in patients with clinical diagnosis of heart failure and there is no significant contraindication. Thank you for your time and attention.
Thank you, Dr. Mitendra. Kindly take your seat. Friends, is about the renal aspects of this wonderful molecule, Dapa CKD evidence to practice. You would remember there was a time when we used to think that a creatinine of 1 up to 1.5 is normal. There was never a concept of eGFR, and gradually we were introduced to this concept of eGFR and the various formula by which we were calculating the eGFR and the renal functions. And gradually we came to know that eGFR is almost the same as Dr. Mitendra Yadav uses for his ejection fraction and to grade his patients. I do not think there was any molecule before SGLT2 inhibitors, whether it was sulfonylureas, metformin, even insulin, which impacted the renal outcomes as much as SGLT2 inhibitors have done since their introduction in 2015. They have actually opened an entirely new field for their treatment, so much so that FDA has now approved Dapagliflozin and other SGLT2 inhibitors even for non-diabetic kidney disease. More to that aspect to Dr. Sahil Bagai. Dr. Sahil Bagai is an accomplished nephrologist in Max. I'm sure he will take us through some important data on Dapagliflozin regarding its renal benefits. Sir, I give you 15 minutes. We wind up this at 10:20 for the question answer session. Thank you.
Thank you, sir. At the outset, I'd like to thank the Physician Forum of India and Sun Pharma for this opportunity. And I'd like to apologize for my background. So we know that the prevalence of CKD has increased by many folds in the last 2 decades. If we look at the numbers, in 1990, kidney disease was 27th amongst the common, amongst all diseases killing people, but it has rose to 18th position. 10% of the global population is having chronic kidney disease and majority of the individuals are undiagnosed. Leading cause of chronic kidney disease, if you see any health economy, is going to be diabetes and hypertension. So we all know that the patient with CKD can be classified into 5 stages based on the eGFR estimation. So from stage 1 would be with a GFR of more than 90, 2 would be 60 to 89, 3A would be 45 to 59, 3B would be 30 to 42, G4 would be 15 to 29, and G5, which is glomerular stage 5, is when a patient is being advocated for renal replacement therapy or transplant. The numbers A1, A2, A3 correspond to the level of the proteinuria. So less than 30 is the normal protein excretion. A2 is moderately increased albuminuria and more than 300, which is quite severely increased albuminuria. So when do you call a patient who have a kidney disease which is attributable to diabetes? So I would take this I would just like to briefly discuss the terms diabetic kidney disease or diabetic nephropathy. So when someone says it's a diabetic kidney disease, it means that a diabetic patient has some kidney disease. It is not going to mean that this is diabetic nephropathy. Diabetic nephropathy should always be used for histological, when the histological diagnosis is available with us. However, if we loosely use the term diabetic nephropathy, then most of the patients should have evidence of albuminuria. They should have diabetic retinopathy, and to accompany this, they should have a long exposure to diabetes. We all know that kidney is a generous organ. Before it decays, it gives you quite a long time of normal functionality. So at the onset, there is a honeymoon period which is called a renal function reserve, wherein you will have a basement membrane thickening because of the diabetes, but the patient is totally unaware of these consequences. Then comes the stage where there is hyperfiltration, and this is the time when you will have a moderately increased albuminuria setting in. With time, with the next 5 to 10 years, you will enter the next phase wherein there will be an overt nephropathy, wherein severely increased albuminuria and EGFR alterations would happen. And then obviously would be an end-stage disease where the nephron number would be reduced beyond sustaining life. So in all these last 5 or decades, we had RAS inhibition as the major backbone of for the nephrologist, and the confidence for the use came from landmark trials like Sita and IDLT, wherein they showed that the slope of the EGFR came with these. So, Dapa has been talked by the former speakers in detail. So, just referring to the mechanism of action in terms of the kidney, we all know that SGLT2 receptors are proximal to the SGLT1. Once you block SGLT2 receptors, the glucose is not going to be absorbed here. It is going to reach the terminal part. Here the glucose is absorbed, but majority is going to be lost. So increased urinary excretion of excess glucose is going to happen. I like to clear this here. It's commonly believed that Dapagliflozin is going to cause weight loss. I happened to interact with Dr. Will Harrington, who was heading the EMPA kidney trial. He was very confidently able to explain that it's not the weight, it's not the fat loss which happens with flozins in particular. It's the fluid component which they eliminate from the body. So we commonly have a myth that they are going to be weight drugs. So SGLT2 inhibition, obviously they cause reduced renal absorption, they cause glucose excretion, and osmotic diuresis is going to happen with them. So they help us in volume depletion and a better blood pressure. So this has been talked by Dr. Mitendra. These are all CVOT trials with flozins. So talking about the renal efficacy with all these drugs. So EMPA, Canvas, the Great TB, Vortex, these are all CVOT trials. But the subgroup analysis showed that they had a wonderful renal sparing effect. So all these showed that the relative risk reduction was far than what everyone had conceived when the trial was being designed. Then with the confidence from the CVOT trials, the people wanted to have a primary endpoint as the kidneys. So there was an introduction of Sweden's trial, followed by Dapa CKD, and the latest to conclude in March 2022 was EMPA kidney trial. They have subtle differences in the enrollment of the cohort in terms of the GFR. So I just like to draw the attention that EMPA kidney had included patients from GFR from more than 20, whereas Cmes and Dapa had patients from more than 25 and more than 30. So now with the conclusion of EMPA kidney, it's concluded that all the patients with more than 20 eGFR can be safely given flozins. So the questions when we use Dapagliflozin are, does it protect the kidneys? Is it safe for the use? Does it prolong survival? And should we actually use it in our patients? So this was a trial design for Dapa CKD. There was a screening period, and then there was a randomization to 1:1, wherein the one cohort was given Dapa and the other was given placebo. At about 8, the trial was intermittently halted because of the overwhelming efficacy. So Dapa CKD was an industry-driven trial that was conducted over 21 countries with 386 sites. 66% of the people were diabetic and 33% were non-diabetic. So if we carefully look at what the cohort looked like was, so overall population was 4,300. Out of these, 2,900 were diabetics. Amongst these diabetics, there was a subgroup of people, which was about 13% people with diabetes who did not have diabetic nephropathy. So when I was referring to diabetic PTDs and diabetic nephropathy, here's the difference. All these people who are diabetic and they come to you with renal dysfunction, you may be tempted to call them diabetic nephropathy. But then this group was one who had histologically proven diabetic nephropathy. This group will fall into nomenclature diabetic PTD. So the baseline characteristics for the placebo and the drug cohort was almost similar. When we talk about the primary outcome, which included the renal as well as the CV deaths, there was a significant relative risk reduction which amounted to 39%. When we come on to renal limited outcomes, where the eGFR was more than 50% decline, and stage renal disease or a renal death, we saw that the hazard ratio was about 44%, risk reduction was about 44%. Talking about CV death or heart failure, what Dr. Mitendra referred to, there was a reduction by 29%. And if you look at overall cause mortality reduction, it was about 31%. So with the advent of Finrenone, with the use of MRA and without use of MRA, Dapa still stood the test of the time and showed that it offered significant benefit to the patients. When we compare about the safety of Dapa with placebo, in people with diabetes and non-diabetics, the risk profile was not different. Again, I would like to stress that there is always a notion that UTI would happen more with flozins. It's not that easy a derivation. I would say that if someone has a serious kind of a UTI or a complicated UTI, that would refrain you from re-challenging the patient with a flozin. However, if you have an uncomplicated UTI, that's not a contraindication to re-challenge your patient. So, once you give a flozin group of drugs, you will see a acute dip in the eGFR. That's the time when you will have to be patient and explain to your patients that an acute fall in the GFR is going to happen. But over time, you see that there is going to be a gain of GFR as compared to a placebo. So, just a recapitulation, so 39% reduction ratio for the primary endpoints, 44% for the secondary endpoints, 31% for all-cause mortality reduction with Dapa CKD trial. So, conclusion was that the patient with CKD with or without type 2 diabetes, Dapagliflozin significantly improved the renal health, significantly improved the cardiac health and overall prolonged the survival. So Dapa CKD added that this one wonderful molecule is an add-on molecule to the existing armamentarium which was inhibitor and ARBs for the nephrologist. These are the all integrated therapies. We know that when we offer a holistic picture to our patient, we need to counsel them for all this, in all the spheres. They have to take care of their nutrition, they have to stop smoking. Blood pressure control is important. RAS blockade is going to be the backbone. GLP-1 RH is the upcoming molecule again. And then lipid management, weight control, metformin, these are all which we shouldn't forget. Over and above, now flozins form the first line of drugs to be added. So this is just a working flowchart which may differ as per the individualization. But once you offer SGLT2 inhibitors to your type 2 diabetes, the most important thing which I would like to draw is that once it has been given to people who have kidney disorders, please make sure that their diuretic dose reduction is done for them. So at least 50% dose reduction of the diuretics should be done when you offer SGLT2 inhibitors to these patients. And the SGLT2 have a very modest HbA1c reduction. And I'll again like to draw attention that this weight reduction which we refer here it's just the water reduction which had happened in all these subjects, and this is not the fat reduction which happened in the patient. I'd like to thank you very much for your time.
Dr. Sahil, thank you. Various aspects of this molecule. My very simple question to you, ma'am, is after the introduction of SGLT2 inhibitors in 2015, all type 2 diabetic patients, should they be on SGLT2 inhibitors? Can we have some decorum, please? This is the main point of the forum. Can you just come in front? You can be here. You can be seated here. Please come here. Please come here. I want all of you to come here. Please come forward, be seated. Ask your questions. That is why we are here. After the introduction of SGLT2 inhibitors, do you put all your type 2 diabetic patients on SGLT2 inhibitors?
I would not say all, but yeah, someone I can take like more than 7.5% is not maintaining on metformin. Lifestyle modification with on metformin, someone till 7% I'm okay. But the moment it crosses 7, not maintaining on metformin lifestyle, I would like to add sulfonylurea as a second drug. Because if there is no contraindication. Because of course there are cardiovascular benefits of this molecule, and if we are not attaining the efficacy, then probably third, fourth drug I can add. And why?
You showed certain charts.
Yeah.
And even Dr. Mitendra Yadav showed certain recommendations from ADA, EASD, etc. And Dr. Mitendra also showed level of recommendations and class of recommendation.
But
my point is, please listen to me, and so because you will give the carry home points to all of these practitioners who see diabetes patients, as much as you see. If 2/3 of all diabetic patients have subclinical ASCVD, if 2 to 3 out of 5 patients have some renal issues of all the diabetics, would you not like to give an agent or a molecule which actually changes the natural history of these outcomes rather than being glucocentric? You only said in your slides that the approach is now changing from being glucocentric to the outcome centric. Now you comment.
But still, I think, as I said, more than 7%. That more or less becomes almost all the patient. But someone 6.9, 6.7, 6.8, maintaining on metformin, I won't be adding just because of the risk of some weight loss, especially the thin patient, elderly patient, and some genetic liver infection. But of course, more than 7%, I think majority of our patients fall in this category. I would like to add for the benefit that you already stated.
I modify my question a little bit. If my patient can afford an SGLT2 inhibitor, will you then put all your patients on SGLT2 inhibitors?
I think it's more of a personal choice. I won't go for SGLT2 for all patients, maybe 98% of patients.
So you leave out 2%, right?
You have to make choices.
Yes, please.
So actually, if you see the ADA recommendation thing, we were just having a discussion about the same thing. So just to clear the confusion, if I may, you have a patient, most of the labs, except Dr. Dan, don't take it personally, okay? So most of the labs fall in a group when you have a 5.7 to 6.2 as impaired glucose levels. Less than 5.7, you call it a normal person, apart from fasting and post. 6.2 onwards is diabetes, although this is our domain, she is the expert. Now if you have somebody having HbA1c 6.5, 6.6, it's an early diabetes, not pre-diabetes. Still the metformin remains the first drug until this contraindicated. Until there is a gross renal issue or risk of lactic acidosis or whatever it is. Why? Because metformin has its own beauty. Heart failure is okay. Only diabetes, we call it as equivalent to CAD, but not that bad. A person just has diabetes, no atherosclerosis. So I was discussing with somebody that if somebody has LDL of 130 or 140 of the Kodak, will you treat it? I said you have to see the age, you have to see if there is atherosclerosis or something. So on top of diabetes, if you see there is atherosclerosis, there is hypertension, there is an LVH, yes, we use it as a first molecule. But you simply have diabetes, normal blood pressure, no LVH, nothing. You would like, because metformin, we all know that it has 2-3 properties. Beta cell preservation, reducing the rate of destruction of the islet cells, or beta cells you can say. So that you can't steal from your patient. Because yes, you will have SGLT2 as the first thing, but then progression of diabetes is another thing. So in these all the initial diabetics, metformin is the one. If you have any added risk factor, you add this molecule. And we know that both combinations are not going to cause you hypoglycemia. So yes, not as a first choice at every time.
And plus we have such a long history of use, no, we cannot forget that. These molecules are a bit newer to us. A young patient coming with 30-25 years of age, I think metformin and lifestyle till 7 works. After that we can add.
I would like to have an opinion from Dr. Sahil on this.
Sir, I would like to differ from both of them in terms that I look this group as as a drug which is going to increase the survival. So one something is offering the survival advantage. I am not going to deprive my patients of survival benefit. I am not saying that metformin is not a good drug. Metformin is a wonderful drug. But just look at something, metformin has been available for 50 years. We all know in and out of metformin. There is a drug which came in 2015. And ADCO was forced to put it as equal to metformin, and it amended the guidelines, citing that if you feel that your patient deserves a single drug, you are good enough to take out metformin, put in SGLT2 in its place. So I think this molecule deserves a pat on the back. And I personally put all my patients on SGLT2 inhibitors with EGFR more than 20. And until and unless, as I said, that the most fearful, or I would say the most fearful myth everyone has is that it may cause UTI. Even though we don't have a guidelines for post-transplantation, we use SGLT2 inhibitors for most of our post-transplantation in and out. We have not seen a flurry of UTIs in our practice. We have not had complicated UTIs. One odd patient could get it. That's what I said. Once you have a complicated UTI, please don't re-challenge your patient. That may be a foolishness to do that, but in case of uncomplicated UTIs, please don't deprive your patients of benefits with this molecule.
Excellent. Dr. Sahil and me would make great friends because I'm a great fan of SGLT2 inhibitors. Dr. Bhawna, I would like to ask you something, we had wonderful concentrated trials on diabetes. One of the best was UKPD. 1977 to 1997, the follow-up of 10 years in 2007. And we saw wonderful results on the microvascular front. But we did not have great results on the macrovascular front. The best result came in the metformin group, and Dr. Mitendra Yadav would vouch that the absolute risk reduction was 15% on MI. For the first time, in the history of any anti-diabetic drug, we found in EMPA that the drug reduced cardiovascular mortality to the tune of 38%, overall mortality to the tune of 32%. So this was the first molecule which actually bridged the macro and the microvascular divide. The first molecule, even insulin did not do that in the most well-constructed trials ever done on diabetes, the UKPDS. Now, I come to my basic question. The first question again, would you not like to put all your patients on SGLT2 inhibitors in the light of this knowledge? Answer please.
Yeah, UKPDS of course was not able to show significant benefit for the macrovascular event. But if we see the follow-up trial, which was published I think last year in NEGM, it has shown that there was consistent benefit in terms of cardiovascular reduction in the intensive arm also. So the trial EMPA-REG, I would say, was conducted in the patient that almost 99% of patients had already cardiovascular disease. So we are getting benefit in those patients, But talking about metformin, here we are talking about a young adult male who is coming to my clinic, diagnosed diabetes, not having any risk factors, I would go for a drug which is there in the market for a long. So that is one subset. And another group, apart from that, I think empirical or Dapagliflozin, they will become the drug of choice.
I'm still not able to bridge the gap between Dr. Bhawna and Dr. Sahil. No problem. I would like to ask you a question, sir. When you choose a drug to reduce or to achieve better renal outcomes, which one do you use? You go by credence data, you go by Dapa CKT data, which was actually prematurely terminated by FDA because of the wonderful results in the treatment arm, or you go by the CKT.
So, credence was the first trial. It gave us a good confidence that these drugs can be used, but it was fraught with some challenges in terms of risk of amputation and UTA. Then came Dapa. It helped us in a significant way by removing these notions that the amputations are not going to be there, the UTAs are not going to be there. And MPOR held us one step forward, that EGFR more than 20, as low as 20 can be operated. So I would believe that all these trials have helped us getting one step ahead of the other. So MPOR technique for me has just opened the gates further, that I can offer my patients from 20 to 25 years this drug. So without a doubt, I think they all exist in harmony rather than challenging each other. And I think MPOR technique trials are more welcome as they were.
There is a subset of patients in the kidney outcome trials which is classified as rapidly declining kidney function, wherein you have an EGFR which is declining either by 3 ml per minute per year or by 5 ml per minute per year. And Dapagliflozin has been found to be very, very effective in that group also. Does that hold true for Dapa also?
So there is no, amongst the class there is not a difference between the molecules. So what Dapa is doing, the similar thing is going to be done by Dapa. So obviously Dapa 10 is equal. In all the trials, Dapa dose 10 mg has been negotiated. So in most of us, in clinical practice, it may be going up till 25 mg of Dapa. But in the trials, 10 mg is shown to be as effective dose as Dapa 10 mg. So I think, as I said, these trials all exist in harmony. And all drugs in the same class are going to also be same.
So I would ask the same question to all three of you. Is SGLT2 inhibitors the new statin of kidney disease? Is SGLT2 inhibitor with the pleiotropic benefits the new statin for diabetes treatment?
Yeah, definitely.
It is. Sir, your comment, most relevant.
I would counter something. Statins have been notorious to increase the diabetes. They have to justify them, they do not. There has been a time that just like interlockers. So the question is framed wrongly. I will criticize you because you tried to put us down despite the jet lag. Nobody can be so energetic despite the jet lag. And this guy is doing that. So one, the question is wrongly framed. You can't say that it's statin for the diabetics, no. Statins have been blamed to increase the diabetes rather than protect it. But overall effect was nothing.
I am talking about the pleiotropic benefits.
Now, as I've told you, I quoted the same thing. The question for me was what? I answered the what? Re-wording the question.
We often talk about statins having pleiotropic benefits.
Yeah.
So similarly, SGLT2 inhibitors have been propagated as having pleiotropic benefits.
Yeah, so
now, do they have the same pleiotropic benefits as statins for a cardiologist? That is my question.
See, there is a relatively new molecule, so cellular biology we are still not. If I tell you, these all are hypothetical reasons how it helps. Still we don't know. Like somebody said that, what are you doing? I mean, this is a whole dark, there is one light somewhere. So they say that, what are you searching here? They said, I dropped my car's key. We said, are you sure that you dropped it here? He said, no, I don't know where I dropped, but light is better here. So still we are not clear. Statins we know by cellular biology that they increase the endovascular function, restoring them. They have the effect on the stabilizing plaque and everything. Here we are still not. There is still no 100% cellular explanation that these agents, what I have told you, this is a possible mechanism, reducing the preload, afterload, reducing wall stress, favoring the positive remodeling rather than negative. So positive remodeling, I should tell you one thing. If anything dilates or weakens your heart, is negative remodeling. Any drug or anything which improves the cardiac function or contraction is positive remodeling. So these are then the natriuretic and then the endothelial function improvement in the soul. So still, but we still have to have clinical benefits we have. So there are so many drugs that we know that they are beneficial. But at what level they are working, we are still searching.
We can't compare two models. How can we compare that?
Dr. Ashok Chakravarti, a very eminent pediatrician from South Delhi, he will ask a question.
Thank you, Dr. Chauhan. Nice meeting you once again after a long break. All the three speakers were excellent in their perspective. I have a question for Dr. Ava, and I think this question pertains to almost everybody in the Dr. Bhawna, sorry, not Dr. Bhawna. A little after the break. It will be true for almost everybody. I'm 70 plus now. History of strong family, diabetic myopathy, diabetic cardiac respiratory disease. I am BMI 30. My latest report of HbA1c was 5.9. And the fasting was 106. Would you recommend me out of the three, which one? Either SGLT inhibitors, metformin, or lifestyle management? Keep in mind, what would you suggest? I'm asking this on behalf of general public.
You did not mention the blood pressure.
BP is normal. I'm non-hypertensive.
You did not mention the lipid profile.
Lipid profile is within normal.
You did not tell us your EGFR.
EGFR when I tried.
So there is a package in Max called Railway Total.
Okay.
And did you get your IMD? Are you having an apparent or latent atherosclerotic cardiovascular disease? Not loud enough. So
you recommend go under the old profile.
So going to so to super specialist, if you're going, you need a detailed workup.
Okay.
To know your 100%. I'm interfering in our answer.
But you're right. It's a general thing.
So you gave us this 30% of the picture.
Of my information.
17 is concealed and we would like to reveal that and then we will give the answer.
Very good. This is what. Very good. So, Dr. Bhawna.
Yeah, so you're saying that over your strong family history of diabetes and your A1C of 5.6 and plus you have centimeter obesity, I would go for lifestyle modification for now. Not going to add you on metformin or SGLT2 inhibitor. You need to reduce your weight. You're going to reduce your weight.
Reduce my weight.
Yeah, nice.
Yeah, as you will reduce what is it? Every Wednesday we have a meeting, so.
Dr. S.K. Podar will have a question.
So, Dr. Mitendra, in the list of heart failure vaccines, is there any role of GLP-1 agonist, considering that there are many cardioprotective effects of GLP-1 agonists?
Sir, to be very honest, we live in an era where we withdraw the drugs, like the latest one being the ranitidine, which is the scan. So for those who are analog, we still need data. We need enough data proven by phase 3 trials and then thousands of patients. So they are having promising, future is promising. They're still working. There are so many molecules, but we still need enough data to make them indicated in all the patients.
Would you go by the data of leader for liraglutide, sir? For GLP-1 receptor agonist? Is that good enough?
Semaglutide, these are all things, they are still in the pipeline.
Liraglutide, leader trial.
We are still searching for the data.
Okay.
We are a huge country and then we need an Indian data as well, Asian data.
So you are not convinced?
Not, this molecule I discussed with her. You will not believe when the reflexes came, I was taught the same physiology, the guidance, Ganon, Chaudhary, whatever. Then if glycosuria is in the diabetes, it is going to damage your kidneys, the Sahil knows. And I don't know whether it is called focus segmental glomerulosclerosis, the typical diabetic nephropathy. So it is related to glycosuria. So every physician used to check the urine iron, how much is the protein, how much is the glucose. These molecules, if you see, if you get the urine iron, if they are really working, glucose 4+, every patient. I was so skeptical that if drug is causing glycosuria, it might be causing. On top of UTI, my customer will be causing renal damage, capillary permeability will be affected and there will be lesions. But then, after enough data, I was convinced. So So I'm still skeptical about this.
Right, sir.
I need more data.
My last question to Dr. Sahil. MPA-CKD and EGFR of less than 20, up to 20 we can use. Dapa-CKD, EGFR of up to 25 we can use, we can start. Credence, less than 30. And Dr. Bhawna actually alluded to MPA-RED. The initial inclusion criteria which was there in MPA-RED was an EGFR of 45. But they included some patients even up to 30. Does it really make a difference? 20, 25, 30? Please explain.
Everyone was skeptical when the diagnosis started. So credence was watchful. They did not want to go below 30. Then Dapa took us right forward. It came with 25. ENPA did it with 20. So what these trials have done was that they have made sure that we can offer these pleiotropic effects or the directly indirect effects to most of the patients who otherwise would not have achieved, who otherwise would not have offered these effects. So obviously, if you don't offer the drugs to someone who has a GFR 20, you are going to lose a chunk of CKD4 patients. So what Credence was doing, it was not offering these drugs to CKD4. Yet we are not offering it to CKD5, that's true. But all these trials from the conditions apply that once you are in stage 4 and you give a drug, they reach stage 5, please don't stop it. So most of our patients till 15, 14 are on these drugs. And honestly speaking, we have not seen any major risk to these group of patients. And people have started to use these drugs in even dialysis cohorts. And we are yet to see some subgroup analysis where peritoneal dialysis patients are given these drugs. To add some legend.
Thank you. Actually, with each trial, we have become bolder. रफ्ता रफ्ता वो मेरे दिल का सामा हो गए, पहले गुल, फिर गुल बदल, फिर गुलिस्तां हो गए. सही बात है? Okay. सर वो तो अलग है, वो शेर अलग है सर. मैंने शेर को चेंज कर दिया, and it is not because of the jet lag.
No, what I am saying is like the noise also. What the size is. Every time, one thing is very important that don't go solo. So even in the case we are practicing. So I tell you to all. When you have a complex situation, you have renal issues, you have cardiac issues, you have diabetic issues. Always involve in the. Like even if I say a 1.3, I wasn't used to say like 1.4, 1.9. But now we know easier. So you will not believe that every week, 3-4 times they poke in the urine organ. Our patient who's got a creatinine like this and that. So in NOAC, we have a cutoff of EGFR, but now we are going for with Epixaban and this one. So GFR is something, as you told, we are getting older and older with the evidence.
You said rafta.
Yeah, obviously.
I said
fully agree.
Good sir. On to some very interesting questions, which is going to test your deep knowledge from a person of great standing, Dr. J.P. Attri sir. Let's clap for you. Before questions. How are you? Sir, ask right questions because you are not jet lagged. I am there.
Thank you, Chauhan, for those wonderful questions that you asked. Because of paucity of time, maybe I'll restrict my questions and comments as well. To Dr. Bhawna, you said 2 to tango. I'll say probably 5 to tango. SGLT1, SGLT2 inhibitors, DP4 inhibitors, GLP1 agonists, and metformin. We know DPP4 inhibitors are cardiosafe. Do they have some CV benefits? I believe recently some data has been published which says DP4 inhibitors probably have some CV benefits. Please talk.
So yes, we have like small study, but I think we want more study on that. But if you talk about DPP4 inhibitor, so neutrality is of course there. So when we're talking about something with a proven benefit, of course we should figure SGLT2 inhibitor with more data, with more efficacy and more prevention aspect.
Ma'am, 6 trials involving 52,000 and odd patients talked about DP4 inhibitors do not really cause any arrhythmias, but atrial flutter is a big problem with this. In fact, 52% of patients on DP4 inhibitors have atrial flutter as compared to placebo. The mechanism is still understood. Would you like to dwell on this?
Sir, I would like to dissect it, I have to be very honest.
Please go ahead.
In PSM or what we call community medicine, when we have a lot of statistics, there's something called diet theory. I don't do it. I take a drug, I take a placebo, I make it patient, it's a control, I just spin the dice. So even with use of dice, you can produce these statistically significant results. You have to dissect who is under trial, how many patients are there.
52,520 patients.
And then anyway, so how many the Asians and Indians?
I'm not aware of that.
So I want to be aware. I have not read through the
analysis
So I want to go in depth
6
with
trials were done, and this was the inference. So I'm not sure. If
So
it
it
was,
must be a
let me complete. If it was not seen, no other arrhythmias were seen excepting atrial flutter. We do not know the mechanism behind it, but you cannot ignore the 6 trials involving 52,520 patients.
Sir, when was the trial done?
This was done about 3 years back.
So far we do not have.
I think you're not aware of it. Anyway, let's proceed further. So, Dr. Yadav, talking about the dual SGLT1 and 2 inhibitors, see, would you say this is a cherry on the cake for the cardiorenal benefits or protection?
One have to still have enough evidence. The SGLT1 still have to have enough evidence about it. 2 we have the enough data. So, and then guideline, obviously you can say, one thing is that we say guideline. But they always say that the guidelines are to guide you, not to dictate you. So whenever you talk about any guideline, you have to keep as a guide rather than a dictator, and then always has to be flexibility with your own knowledge and experience, and then you have to see your patient profile, and then you have to tighten those on.
Let me proceed further with the JAK, which published an article just last month talking about the ACHD with heart failure. So, which has revolutionized the treatment here. Would you like to dwell on this?
We still, for these things I told you, that this is what we are talking about. We are having coming data. And then we are very strict. We believe in 2-3 forums like Madina, ACC, AHA, ESC. So now we got the ACC, American Cardiology Forum, whatever you can say. So until we have the data enough to support that, we can't use it.
So this represents a progress and practice-changing guidelines in the nasal field of ACHD heart failure, which has revolutionized the treatment for such type of patients.
Obviously there is enough. I mean, the therapy is evolving. And we are going in the next coming 2 or 3 years, we will be able to run.
Let me proceed further, sir.
Sir, Dr. Sahil is feeling left out. Some questions.
Let me proceed. Last question with it.
Yes.
How do you prioritize and you see drugs like the 4 fantastic drugs, but you probably start with SGLT2 inhibitors and then the other 3 drugs and give in small doses first, then probably titrate, upward titration, which would be better than giving a single drug with a high dose in heart failure.
Obviously, this is a perfect point. So then they say that rather than starting one drug and achieving, like if I start earning, I start with 50 milligrams twice day and I target the 200 milligrams twice day. This is not the goal. They say that you should start multiple drugs with tolerable dose and then you up it. So rapid sequencing is to involve the as maximum possible drugs, and then if you see that something is not being tolerated, you withdraw that, and then you upfront you build. So you can get the aided advantage because every drug is a different mechanism, and then I 100% agree that you should start with the minimum possible tolerated dose of as maximum possible drugs, and within 4 to 8 weeks of time, you build up the tolerable dose. And then definitely your patient is in favorable response. Even from the 90 systolic blood pressure, he can go from 50 half pp of army to the full dose of army.
Very rightly said. Let me proceed with Dr. Bagai. So, Dr. Bagai, when we give drugs like SGLT2 inhibitors, you expect eGFR in the first few weeks to dip. eGFR reduced by about 10%, is creatinine level high. So these drugs, in the first few weeks probably would, eGFR will be reduced. There's a dip there. But you need to continue, friends, this drug, not only this, even with the MRIs for a few weeks. Yeah. If they are more than 30%, probably you need to take a break. Talk about this.
What Dr. Tulsi said, will the EGFR reduce with every SGLT2?
So, it's a physiological dip which is going to happen with these drugs. And as I said, sir, we all have to be patient. At times the private practice is going to take over your consciousness, and there would be incidents where the people would try to discontinue drugs. But as I said, we have to be patient, we have to be honest with the patient. You have to explain to your patients there is going to be a dip. If it is more than 30% rise, you have to be wise enough to stop the drug. And the other things that I would want to say is that diuretic dose adjustment needs to be done when you offer SGLT2. Most of the time we don't offer diuretic adjustment. That's the time when they go into some pre-renal injuries and the creatinine might be over seriously high, and we may stop the drug unknowingly and we do more harm.
My two questions to you regarding use in dialysis patients. See, do you use this drug and SGLT2 inhibitors in dialysis patients? What I'm saying is because probably, they may directly or indirectly have some CV benefits, with these drugs. They reduce mortality even in patients who are on dialysis. Talk us about this, SGLT2 inhibitor in dialysis patients.
So, the benefits. The reason why the SGLT2 inhibitors were not given in dialysis patients was because they are not going to have any natriuresis. These set of
agreed, but some direct or indirect effects are seen. They reduce mortality, they reduce CVD.
So there was a recent trial published in Cmes wherein they saw that the peritoneal dialysis patients were given these because they had some residual renal function. And they had some pleiotropic effects, and that's what they have now tried to include dialysis patients even, and they might come with subgroup analysis.
One last question, sir, because before Dr. Chauhan says that we are going to wind up. So, would you say it's prudent to discontinue SGLT2 inhibitors if there is an acute renal event, or if you have hypovolemia or dehydration?
Yes, sir. So
thank you, sir.
Same day rule would apply.
Thank you.
Dr. Gargar sir will have the last few questions, and then Dr. Bhawna, I will ask you the very last question from my side, which is very dear to my heart.
Very nice talk, dear friends. मैंने जगह बदल के भी देखी, लेकिन मैं हूँ लास्ट डब्बा. Anyway. मैं डॉक्टर चौहान के पहले सवाल को थोड़ा सा ट्विस्ट करके पूछ रहा हूँ. Suppose patient को diabetes भी है और hypertension भी है. Would you like to add this in place of your favorite sulfonylurea?
Yes, definitely. As I said, metformin, no other problem. No centripetal obesity, no dyslipidemia, no hypertension, no family history of CAD. But I think in our practice, our patient will have one or the other risk factor which may lead the ASCVD risk. So that patient definitely becomes the doctor.
Especially if the patient is obese also.
Yeah,
and Dr. Mitendra sir, but where is the place of Dapagliflozin maybe in future for a patient of hypertension, non-diabetes, because it's also a factor, it's a risk factor for heart failure.
Isolated hypertension stage 1 without any target organ damage. Left ventricular hypertrophy, left atrial enlargement, LV systolic or gastric dysfunction, some amount of MR or AR, or maybe dilated aortic root, or atherosclerotic effects of hypertension, or some sort of nephropathy, or some sort of retinopathy. If no, then no. If you have that, your patient becomes stage B hypertension. or stage B heart failure, then obviously I consider that there is a silent heart failure sitting. So without absence of these kind of serious things or comorbidities or effects of hypertension,
And it's difficult to find anyone without all these. Anyway.
no, so it's not like that.
Anyway.
If you see 30% of the people, no, I'm finished. 30% of the people below the age of 30 years have hypertension. And you do not pick up them. Most of the people say, BP बढ़ गया था, चल क्या है. So this is something which is very underreported, and we pick them up at that time. That time is the best time to pick them up. They do not have a target organ damage. So once you have a target organ damage, brain already छूट चुका है. तो सब जो use करना पड़ेगा.
Right. You mentioned about 3 beta blockers. So this may be also a choice for those who are not tolerating others,
No.
or especially those who are having.
Maybe Valon doesn't sit into that group. We see that it causes nitric oxide release and causes some osmolality.
I'm thinking
But
of-
it still does not qualify the 3 beta blocker.
I'm thinking of patient of ED, the patient of ED, when all others are having additional effect to ED.
Dr. Sahil is one of the nephrologist very close to the endocrinologist or whatever, and she is an endocrinologist. I tell you, the myth about the beta blockers and ED, I tell you. The patients who have got the ED with the beta blockers, 95% of them are ED because of psychological factors. With a metoprolol doses of 200 milligrams once a day, if 10 patients are ED, less than 1% will actually have because of beta blocker, most of them are because of psychological effect. So it is an over-reported thing causing underutilization of beta blocker. So no, nothing. If a patient is having heart failure, risk of heart failure, maybe we'll all big no. I will go for these or 3 beta blockers.
My last question is, some of the very eminent endocrinologists are using SGLT2 twice a day. What's your experience?
I think we are mostly the molecule and she's the best person for it.
It should be used once a day. I don't think there is much benefit in eating because we don't have a data also. And once a day is quite good in terms of efficacy and safety.
First of all, a comment and then a question. Dr. Mitendra Yadav wanted to stay exactly for half an hour. Dr. Bhawna Attri wanted to leave exactly after half an hour. I was not sure after Dr. Sahil Bagai how long he wanted to stay. Can you believe these gentlemen and the lady? I think here it is 11 o'clock. Still answering the questions. That goes to show that this CME by Sun Pharma has been an excellent CME, and it has been able to carry home give you some carry home points for your day-to-day practice. My last question, ma'am, very dear to my heart, and any of you can delve into this. The basic pathophysiology of type 1 and type 2 diabetes does not differ as far as endothelial dysfunction, accelerated atherosclerosis is concerned. The only thing that differs in type 1 diabetes and type 2 diabetes is probably the insulin resistance. SGLT2 inhibitors have been found to be of great benefit in type 2 diabetes. Do you think in future SGLT2 inhibitors will find a place in the treatment of type 1 diabetes?
Sir, we'll always...
And sir, I am not time left, I can assure you.
I'll tell you, I'll prove it. You have. I come to.
So there is a risk of euglycemic ketoacidosis attached to the SGLT2 inhibitor, although it is very low.
Ketoacidosis.
Yeah, ketoacidosis.
Okay. If I put my patient on insulin and then give him a support of SGLT2 inhibitor to achieve the same pleiotropic benefits that I achieve in type 2 diabetes.
I don't think that whenever we have a type 1 DM patient, you must be seeing many of these patients at least once or twice a year end up in diabetic ketoacidosis.
My question is different. I am saying I put them on a good cover of insulin and then I give them insulin. And then I give
The
them
risk of decay is very, very high with these
Okay,
patients.
so because of the issue of ketoacidosis, you would not like to give.
Of course not now, till the time I don't have much data and much experience.
Right. So my question comes to Dr. Sahil now. For type 1 diabetic patients, do we have potential benefits with SGLT2 inhibition?
theoretically yes, but all the studies and all the trials which have been done, they have rightly excluded type 1 and the trials which have included type 1. They showed that they reversible effects, but most of the renal patients were not included. So I think we are yet to draw a conclusion that they can be.
Neither here nor there. Dr. Mitendra, sir, your final word on usage of SGLT2 inhibitors in type 1 diabetes for cardiac benefits.
I don't know why we are so partial on type 1, type 2 diabetes. We don't talk about type 3, type 4, type 5, Modi, and everything. We are biased to that. So going to the pathophysiology of the both diabetes, once we have an insulin resistance, the circulating insulin is very high, your cells are not sensitive. So this is one of the molecules like metformin and others which is going to sensitize the cells. Apart from just causing glycosuria, its mechanism is different. In type 1 you have a lack of insulin, beta cell destruction grossly. And then a lack of insulin is totally different than the resistance of insulin. I am not that great endocrinologist. But then the those patients having a significant risk of ketoacidosis. And what is the treatment of ketoacidosis? What we do?
Insulin.
IV fluid. Apart from insulin, they are dehydrated. You give liters of, I still remember MPDs, 18 gauge candle of both ends, free fluid, normal saline. Watch the potassium, because once you're giving insulin, you will end up with hypokalemia and VTVA. The molecule you are giving is causing glycosuria, significant diuretic, increasing much more chances. So still fingers crossed till you get the great data.
I asked the question, Dr. Mitendra, specifically to Dr. Bhawna because we have been told, we have been educated and we have been literated on SGLT2 inhibitors that it has an insulin independent action and therefore that
but the glycosuric action and high.
Therefore the question and the potential benefits in various aspects to all the three learned speakers. The final comment by Dr. Bhawna and we are going to wind it up.
But so the risk of PK is too much with the kids that we see now.
Understood, ma'am.
All of my patient, I won't say that they are very well controlled. Only few of the type 1 DM are the ones who don't have PK in the last 4 to 5 years. But taking a risk to those kids is, I think, it's very risky to give them SGLT2 inhibitors. And that is the one thing which is stopping. For type 1 DM, when these complications start at least after the 5 years of diagnosis, they are not there at the diagnosis. So we can very well manage them with insulin only from the beginning so as not to have the complications.
Great defense, Dr. Bhawna. Wonderful, wonderful CME, Dr. Sahil, Dr. Bhawna and Dr. Mitendra. I am so very grateful to all of you to have come over and to have participated in this landmark CME. I am sure